This is a case of a brown cataract with an iris coloboma. By now, side ports are made, and under the air bubble, trypan blue dye is injected into the anterior chamber to stain the anterior capsule. Now viscoelastics are injected into the anterior chamber to completely remove the air bubble. Using a 26 gauge cystitome needle, a 5.5 mm capsular excess is performed. Make sure that the flap ends are facing downwards to prevent the runaway of the rhexis. Now, a 2.8 mm keratome is used to create a biplanar corneal incision to gain entry into the anterior chamber. Now, hydrodissection is performed with a hydrocannula. Phacoemulsification is now initiated in the Phaco-1 mode by creating trenches. As you can see, sufficient power is required for trenching in these hard cataracts. Now using two choppers, the nucleus is cracked by engaging the ends of both the instruments at the base of the trench and gently pulling them apart. The nucleus is now rotated and in a similar fashion, the crack is now initiated from the opposite pole. Now switching to Phaco-2 mode, the probe is buried into the core of the nucleus, slightly lifted up, and the chop is initiated. The nuclear fragment is then broken down into multiple pieces and then phacoemulsified. The other heminucleus is then rotated and the same procedure is again repeated, making sure that the phacoemulsification takes place at the pupillary plane. The epinucleus is also aspirated with the phaco probe. Viscoelastics are then injected into the anterior chamber before withdrawing the probe to prevent the prolapse of the vitreous through the weak zonules. Now, bimanual irrigation and aspiration is initiated and the cortical fibers from each respective quadrant are gently stripped and aspirated. Now, a hydropolish is done to clean the posterior capsule of the remnant cortical material. Since colobomas have a weak capsular bag, capsular tension rings are used to stabilize the bag before the insertion of the IOL. First, one limb of the CTR is introduced and the trailing limb is gradually and gently dialed and tucked into the capsular bag and underneath the anterior lens capsule. The intraocular lens is then gently injected into the capsular bag and dialed into position. On retroillumination, you can observe the limb of the CTR next to the haptic of the intraocular lens. Now we plan to repair the inferior defect in the iris. Two side ports are made on either side inferiorly. A 23 gauge intraocular forceps is used to grasp the iris to get a mild countertraction, and a 10-0 straight Proli needle is used to pass through the iris which is then brought outside. In a similar fashion, the Prolene needle is passed through the 27 gauge needle by the railroad technique, which is then brought outside. A loop is made on the other end and brought outside through the side port. Now, the loose end of the needle is passed into the loop 4 times. This is done to avoid any slippage of the knot. Now, both the ends are pulled gently, and as you can see, the iris tissue are brought together. The knots are trimmed using the intraocular scissors. The viscoelastics are washed from the anterior chamber. The side ports are hydrated and the anterior chamber is filled with an air bubble and the case is closed. This is the preoperative hard cataract and coloboma. 1 week post-op showed a resolving corneal edema. 1 month post-op showed a clear cornea, well-centered intraocular lens in the bag, with a fairly round pupil and a good visual outcome.